Good morning, dear colleagues. It's not a scientific presentation. I was requested to try to introduce you into a model of global healthcare services applicable to clinical cardiology, personalized precision medicine, like an overview. Unfortunately, this personality died, but it's fantastic. Number one in the world in autoimmunity conditions. But we were so close friends. Might be he visited me in Moscow 10 or 12 times. It's phenomenal personality, Harvard Medical School and University Johns Hopkins. New targeted therapies for autoimmune and inflammatory diseases would require greater understanding of a patient and now of a pre-illness person at risk to get the therapy personalized for either of those subsets. In this sense, the identification and further application of diagnostic, canonical, predictive and prognostic new generation biomarkers remains the holy grail of PPM, personalized precision medicine related, and translational platforms. Biomarkers enable pre-early, pre-illness or subclinical diagnosis, guide targeted therapy, and monitor the activity and therapeutic responses across the disorders. Just look, please. Sources and types, strategies for discovering biomarkers. Among the best validated predictive biomarkers are autoimmunity ones to predict and to prognosticate risks of the chronification, complications, and disabling. Just look overview of the most popular and beneficial biomarkers of chronic autoimmune diseases. This is a table gifted me by my friend, the dean of the medical school in Tel Aviv, Professor Yehuda Schonfeld. The latter is so much valuable and important since chronic autoimmune inflammation course is structured to consist from different stages, including subclinical and clinical ones. Please look at normal immunity. No problems. Benign autoimmunity, stage of subclinical autoaggression. Pathogenic autoimmunity, stage of full-term autoaggression resulting in clinical illness. Autoimmune myocarditis and inflammatory dilated cardiomyopathy. A continuum can be identified between those two conditions. The importance of pre-early, as I have mentioned, subclinical diagnosis being based on specific autoantibodies has grown markedly in the contemporary era with various diagnostic and predictive tools available today. Recognition of the pathology-driven pathways reading the molecular full-term molecular profile and confirmation of the evidence-based precision subclinical diagnosis may help understand mechanism of progression, tailor long-term preventive this complex diseases. Sorry. I have been flying 16 hours from New Zealand. It's a big problem, not restored. Meanwhile, autoimmune responses and inflammation are involved in the pathogenesis of many cardiovascular disorders, including AIM, autoimmune myocarditis. So, AIM is just one of the tissue-specific inflammatory autoimmune heart diseases triggering immune-mediated pathologic mechanisms that produces autoantibodies which attack one's own heart, leading to myocardial damage and dysfunction, and thus to a set of heart-associated signs or symptoms. Due to the large variability in clinical presentation, unpredictable course of the disease, and lack of established causative treatment, AIM represents a challenging diagnosis in modern cardiology. Moreover, an increase in the incidence of AIM and IDCMP has been observed recently. It's just the illustration of pathological process leading to the persistence of inflammation and progression for AIM, resulting in chronic inflammatory cardiomyopathy. Just overview. The crucial step in the pathogenesis of AIM is a primary cardiomyocyte damage, which is mediated of autoantibodies to trigger a release of separate and pathogenically valuable cardiac epitopes into the bloodstream. Those epitopes act as sensitizing factors to generate autoantibodies more and more, which in turn would drive the autoimmune inflammation, progression, and cardiac tissue damage. Just the overview of cardiac tissue autoantibody mediated direct attack, just schematically. The management of AIM is complex and should be multidisciplinary, including a cardiologist, cardiovascular precision pathologist, and clinical immunologist. Thus, to a uniform approach to the diagnostic process in this case, being based on personalized biomarkers and precision diagnostic technologies is strongly recommended. As applicable to AIM, multiple biomarkers have been extensively studied, with increasing evidence accumulating to support their clinical usefulness in acute myocarditis and IDCMP. Biomarkers are routinely used in clinical practice in AIM and IDCMP, and the continuum has been defined with a role, possibly or definite, for community-based screening, diagnosis, risk stratification prognosis, phenotyping, management monitoring, and finally, treatment. However, none of the canonical daily used biomarkers has demonstrated sufficient impact alone in the management of AIM and IDCMP. Thus, it has been suggested that the integration of multiple biomarker sets or development of the principally new biomarkers may represent promising new strategies in AIM management. A relatively new area of modern diagnostics in AIM and IDCMP is the study of diagnostic predictive significance of a number of biomarkers in non-invasively obtained body fluids, including blood, and the development of omics-driven technologies for cardiac biomarkers, in particular for IM and IDCMP. So omics portfolio. In the near future will allow a rapid, express diagnostic at home to monitor AIM as the autoimmune conditions before being hospitalized. It's just an overview of the AIM related biomarkers now under the study. One of the most sensitive and specific biomarker-driven criteria for detecting AIM are cardiac troponins and their molecular isoforms, which are regulatory protein molecules that are released into the blood serum from CMS upon their death or damage during AIM multi-step progression. Just look at traditional biomarkers of cardiac damage. Importance of the localization. Troponins, just for example, can be used to test for cardiac injury due to AIM. Interestingly, some patients develop heterophile autoantibodies that may facilitate persistently elevated CT levels, while theoretically the presence of troponin autoantibodies might contribute to false negative results in paradox. High sensitivity CT assays. Also, troponins are not specific to identifying cardiac injury, specific to inflammatory damage. They do have a role in testing patients with not confirmed, suspected case of AIM. Accordingly, new high-sensitive methods, omics-driven methods, for detecting anti-CT autoantibodies allow the detection of minor changes at the earliest, including subclinical stages of AIM, and can therefore change the understanding of disease development mechanisms and open up new diagnostic, predictive, and prognostic possibilities. Some other biomarkers have been investigated in the setting of AIM and IDCMP. However, they have not yet entered into daily clinical practice. and are their current role is limited to the research field or only in the frame of the referral sectors. For instance, mRNA have a critical role in regulating gene expression through mRNA and have been extensively investigated and assessed as a very high and high utility and both AIM and IDCMP related clinical practice. Just look around. Of those, some types of mine, doesn't matter, RNAs have demonstrated the highest potential as biomarkers of myocardial inflammatory state. Serum levels, not in situ, serum levels of those microRNAs have been associated with the diagnosis of IDCMP and exhibit high specificity. Following the above mentioned, in addition to biomarkers being important for accurate I mean precision diagnosis and prognosis of AIM in patients, they also open the door, green door, to new therapeutics for the latter. One of the most promising areas of applied research on this topic are circulating microRNA as biomarkers for AIM. Several microRNAs have been found to be elevated in the setting, pre-early setting of AIM. And those microRNAs target genes implicated in inflammatory regulation, controlling the autoimmunity, cardiac injury response pathways, and differentiation of several important immune cell populations. We can utilize this information mentioned to develop gene therapies for either mimic those microRNAs or silence them, depending on their function, to mitigate the symptoms of AIM as well as control inflammation and disease progression as a whole. Undoubtedly, more studies investigating the role of microRNAs in AIM are highly warranted, particularly clinical studies assessing microRNAs as potential diagnostic, predictive, and prognostic biomarkers are highly desirable and thus highly beneficial. MicroRNAs may play an important role both in the primary diagnosis of myocarditis as well as in the differential one. Sorry. Very few comments, but it will be later after the lunch.
10 minutes, so you still have
5 minutes?
10. You still have
Ah, not half a minute?
no 10.
Ah, okay, it's okay. No,
Sorry.
yeah.
I'll show you the photo.
I'm concerning prognosticable, but not mine. Meanwhile, very few. Later, in a couple of hours, I'm scheduled to have the second presentation would concern and autoantibodies of the next step generation. Meanwhile, along with canonical antibodies, you're much familiar with those. Some of the families proven to occur are antibodies possessing with catalytic activity. Zymes, antibody, zymes, enzymes. And thus to belong to antibodies with the feature of functionality. The examples of antibody proteases are usually IgG, found in a series of autoimmune disorders, to cleave targeted autoantigens and thus to act as informative and reliable biomarkers to monitor both clinical and subclinical courses of disorders. For instance, bronchial asthma, vasointestinal peptide, VAP. Cutting targeted sites for attacking by antibodies. In autoimmune thyroiditis, to cleave thyroid autoantigens. Multiple sclerosis, MBP, myelin basic protein. And finally, a big family of antibody proteases detectable in AIM to cleave only cardiac myosin and then to damage the myocardial tissue utilizing their functionality. As you might see, there should be more focused research on studying the role of antibodies and autoimmunity in the pathogenesis of not only AIM, but also in the development of IDCMP as complication during the progression. In this context, omics studies in AIM patients should be crucial to identify genetic association for prevalence of cardiac autoantibodies and their types, and for susceptibility for autoimmunity in IDCMP. So, further studies on antibody-mediated cardiac myosin targeted degradation and other targeted antibody-mediated proteolysis may identify biomarkers of new generations or even new biomarker families, and thus supplementary tools for assessing the disease progression and predicting disability of patients or pre-illness persons at risk. So the field of cardiology is evolving to provide the practice with biomarkers of principally new generation today, which are applicable for biomarker-driven targeted therapy, which is crafted as per the omics technologies for deep endophenotyping. In this context, PPM has helped in targeted management, allowing subclinical diagnosis, timely, precise intervention, and exposure to minimal side effects despite those great impacts, overcoming the barriers to implementing PPM related resources is strongly needed. So thank you for your patience and sorry